Sir, we can start now.
Okay. So, sir, a very good evening to all the eminent doctors. Thank you so much for joining us for today's webinar. Our endeavor is to spread awareness about rabies, which is fatal but can be avoided once appropriately vaccinated. So, this is an initiative from Cadila through its innovation to serve the society and humankind. The topic of the webinar is novel three-dose Z protein vaccines, ultimately for compliance. Dear Doctor, rabies is the world's first novel three-dose anti-rabies vaccines, and with great pride, we would like to inform you that rabies has successfully completed 1 year of launch with more than 40,000 annual bite victims being vaccinated. Doctor, 100% compliance was recorded and no case of adverse drug reactions was registered. With this, it is my honor to introduce you to the speaker of the day's webinar, Dr. Dilip Kumar Jha sir. Is a general physician and practicing in Raj Rajeshwari Hospital, Faizabad. Now I would like to request Dr. Dilip Kumar Jha sir to initiate talk, and later on we will have a question and answer session. So all the participants can drop their questions in the drop box, and we will read out all the questions after the presentation. So hand over to Dr. Dilip Kumar Jha sir.
Hello everyone, good evening. I am Dr.
Good evening,
Dilip Kumar Jha, talking from Raj Rajeshwari Hospital, Ayodhya. So we have a very nice topic today on a rabies vaccine. I hope I am clearly audible to you, everyone.
Yes, sir.
I had a bad sore throat for past 2-3 days, so my voice might appear croaky and unpleasant. That you have to bear with me. Let us start the presentation. So today is novel 3-dose G protein vaccine ultimate key for compliance. Rabies is a public health challenge in India. Globally, 59,000 human deaths annually happens, and highest in India. India had 20,000 human deaths a year from rabies, accounting for 60% of rabies deaths in Asia and 35% of global deaths. 91% deaths in India occurred in rural areas. So next. So what is the current management? Local wound treatment, first aid, active immunization vaccine, passive immunization, RIG, rabic immunoglobulin. So 5 dose, the is an intramuscular regime. Category 2 or 3 exposure. First, we do on toilet. Then RIG in case of category 3 exposure. Day 0. This all happens on day 0. Then you have the vaccine on day 0. Then on day 3, day 7, day 14, and day 28. That is the prevailing standard WHO regime of 5 doses. That was also corroborated by Center for Disease Control at Atlanta. Vaccine is administered intramuscular in deltoid upper arm or anterolateral aspect of thigh only, never in gluteal region. So that is the way of current management. Wound site is cleaned, and then post-exposure prophylaxis and vaccination is done. So what are the current challenges of post-exposure prophylaxis? Number 1 is non-compliance. Current rabies vaccines are cell culture vaccines, CCV. Inactivated vaccines are more than 50 years old technology. Inconsistency in potency, stability, availability, short supply, and adverse events. The compliance, anti-rabies vaccine. Compliant are those who receive the full course of ARV, that is the scheduled dose of ARV on the recommended dates. That is a compliant part of anti-rabies vaccination. Then there are delayed compliance, who completed the scheduled dose of ARV within 60 days, but deviated from the scheduled regimen. Then there are dropouts or non-compliance, who had taken at least 1 dose of ARV after animal bite, but not completed all the scheduled doses. So, limitation to 4-dose WHO recommendation. Rabies post-exposure prophylaxis in the routine practice in view of the new Center for Disease Control and Prevention and WHO recommendations. A retrospective analysis done at travel clinic, a total of 110 patients who received rabies 4 dosage post-exposure prophylaxis. Shortcomings in the management of these patients were late initiation of rabies PEP in travelers, administration of human rabies immunoglobulin H-rich, and antibody levels less than 0.5 international unit per microliter in 6 or 90 patients, 6.7% after 4 doses of vaccine. So conclusions were patients do not always receive optimal rabies PEP under real life conditions. That is the truth of today. A significant proportion of patients did not develop adequate antibody levels after 4 doses of anti-rabies vaccination. So non-compliance to 5-dose proven cause of death. Here you have some cases. A 58-year-old female street dog that was killed soon. 3 doses purified chick embryo cell vaccines, rabies for 037. No rabies immunoglobulin was given. Chronology of events, clinical features, dog bite category 3 at the right side of nose, 20 days paresthesia of face, 20 days fever, and restlessness 5 days, altered sensorium 1 day. CSF finding total cell count 5, monomorphs 100%, protein 1.126, sugar 71, and negative staining. Diagnosis: rabies encephalitis. Confirmatory traits: raging serum and CSF virus neutralizing antibody titers, and respectively after 5 days of the previous sample. MRI finding: bilateral brain stem, mild hyperintensities without any restricted diffusion or contrast enhancement on day 2. Outcome: first treatment modified Milwaukee protocol from day 1. Outcome: hospital survival of 16 days but died after 1 day due to llama. Second case: a 38-year-old male, street dog bite, status unknown, whether it was killed or ran away. Post exposure 3 doses, vaccine type unknown, 037, no rabies immunoglobulin. This was a stray dog bite and dog had run away from the site. So status was unknown. Chronology of events were dog bite category 3 at left mid calf 15 days, dysphagia and restlessness for 3 days. CSF finding not done due to llama, patient also run away. Again, rabies encephalitis and same outcome. The third case is again street dog bite, again a status is unknown, 3-dose vaccine type unknown, 037, no rabies immunoglobulin, dog bite category 3 at right dorsum foot, 17 days dysphagia and restlessness, 3 days dyspnea, and CSF finding total cells 60, monomorphs 100%, protein 84, sugar 58, corresponding sugar 122, negative staining. Diagnosis: rabies encephalitis. Confirmatory tests were done. Rabies RNA PCR positive from CSF and serum, but virus neutralizing antibody titer was not done. Not due to early death, MRI was not done. Modified Milwaukee protocol from day 1 was followed, and that this patient also expired on day 2 of the admission. So the reason of death may be due to lack of administration of rabies immunoglobulin or poor compliance to vaccination. Here is an original article: compliance to post-exposure prophylaxis among animal bite patients, a hospital-based epidemiological study. Mansi Panda and Risha Kapoor had from the Department of Community Medicine, Bardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. At Safdarjung, New Delhi, 360 animal bite patients were studied. A pre-designed, pre-tested, structured questionnaire was administered by the interview technique. 53% were non-compliant due to the full course of ARV. In this pie chart, you can see only 48% were compliant, 6% were delayed compliant, and 46% were non-compliant. So, brief research article: compliance to anti-rabies vaccination in post-exposure prophylaxis. This is a study. Ravis Hardanhalli Sankaraya, Rachna Anandani Rajshekar, Vijay Shankar Veena, and Aswath Narayan Dodavali Hanumatayya. At Municipal Corporation of Hospitals, Bangalore, total number of 215 animal bite patients, 1 dose of rabies vaccine administered intramuscularly on day 0, 3, 7, 14, and 28 as post-exposure prophylaxis. Also, measures constraints for compliance to complete course. Also, measures were constant for compliance to complete course. Compliance to anti-rabies vaccination, day 0, 100%, everyone took. Day 3, 88% only. By day 7, 85%. By day 14, 70%. By day 28, 60%. So compliance rate for intramuscular rabies vaccination was 60%. Yeah. Total dose compliance was only 60%. So constraints for compliance to complete course of anti-rabies vaccines: interferes with school timing 11%, distance of the hospital 11%, cost incurred 30%, travel cost, vaccination cost, and forgotten dates were 18%. So the major constraint for compliance to complete ARV was loss of wages. Evolution of rabies vaccine. In 1885, live attenuated vaccines were taken from spinal cord. By 1911, inactivated vaccines brain up to 10%. And by 1976, we had better option of cell culture inactivated vaccines. Non-compliance led to evolution of treatment regime from 31 dosage to 5 dosage and is still on. So 1885, we had 31 doses. By 1911, 14 doses. And then 1976 onward, it was a 5 dose. Meeting the unmet medical need. So there was a need, a short course, a dose that can be complied by everyone. So there was a medical need in this area, and there we are introducing a novel vaccine with simple and shorter regimen. Novel 3-dose recombinant rabies G protein vaccine, first vaccine with 3-dose intramuscular regimen, 0, 3, 7 days. It has better compliance due to easy to flow regimen and less visits. It is convenience, ready to use, no reconstitution needed. It is prepared by VLP platform technology, first protein subunit vaccine. So novel 3-dose recombinant rabies G protein vaccine is the need of the hour for a better compliance in anti-rabies post-exposure prophylaxis. What is VLP technology? G protein is difficult to stabilize. The native virus, rabies virus, which is a bullet-shaped virus, it has G protein which is difficult to stabilize. And using VLP technology, it is purified and stabilized by this Cadila Pharmaceuticals Limited. Virus-like particles are protein complexes that exist as nanoparticles. VLPs are similar to native virus particles, but that do not contain the viral genome. They cannot replicate, but can mimic the viral antigenicity without being pathogenic. That is the beauty. They are capable of inducing a strong humoral and cellular immune response. VLPs as vaccines, that's why it's acceptable. So clinical phase 2 study design was for 0, 2 doses and 3 doses, 10 microgram and 50 microgram. Seroprotection data were obtained. By day 14, we had 100%. Day 42, it is 100%. Day 90, 100%. By day 180, a little less, 90% in dose 1 and 2. And day 270, we had almost 90 to 100% seroprotection. So clinical study phase 3, safety and immunogenicity of novel 3-dose recombinant nanoparticle rabies G protein vaccine administered as simulated post-exposure immunization, a randomized comparator-controlled multi-center phase 3 clinical study. Phase 3 study to evaluate immunogenicity and safety of rabies G protein vaccine administered as a simulated post-exposure immunization in healthy volunteers. Randomized comparative controlled multi-center study. Total subjects were 800 and randomization was done at the ratio of 2:1. Travis vaccine, 037 days regime, 037 versus 037 14 28 days regime of earlier Rabipur vaccine. We have on both sides, Travis and Rabipur. 533 subjects of Travis and 267 subjects in Rabipur were studied. Total 800 subjects. So results were efficacy, seroprotection on day 14 in both cases. Travis 99.24%, whereas on the Rabipur it was 97.72%. By day 42, in Travis, 98.69% was the seroprotection, and Rabipur it has 100%. The results were consistent across different age groups and genders. Observed difference 1.52% with 95% confidence interval to 4.17% with the pre-specified margin of -4%. Non-inferiority of seroprotection primary endpoint day 14 and 42 were met. Test and comparator are identical in seroprotection rate both on days 14 and 42. The safety aspect. Novel 3 dose has better safety profile as significantly less adverse events compared to reference vaccine. We can see in this bar diagram, Travis only 99.9% adverse events, Rabipur 17.2%. In local adverse events, localized pain only 7.69% in Travis vaccination, 13.56% in Rabipur. Redness only 2.81%, swelling in only 0.75% in Travis vaccine. Fever were noticed in 0.36%, ear pain in 0.19%, headache in 0.38%. All were lesser than the other vaccine which was used or which is being used even today. Urticaria, joint pain, and nausea, all very, very insignificant as compared to the prevailing vaccination. So study conclusion was, novel 3 dose was non-inferior to reference vaccine, less adverse effects compared to reference vaccine. Novel 3 dose was found to be safe and immunogenic and was comparable to 5 doses of WHO pre-qualified vaccine. So for this, the Pharma Innovation of the Year by the Economic Times award was given. The Golden Globe Tigers Award in Malaysia for Innovative Product of the Year, this vaccination has got. So in a nutshell, we have a new novel approach in post-exposure prophylaxis of rabies, anti-rabies vaccination, and it can be used confidently and efficiently. Thank you. Thank you very much.
Thank you so much, sir, Dr. Dilip Kumar Jha, sir. Very, very thank you, sir, for your informative talk. We truly appreciate your effort. Sir, last but not the least, we would like to inform you that Travis has also won the 2 prestigious award in innovation category, sir. ET award, as you told, sir. ET Pharma award and Golden Globe Tiger award. So, sir, once
Yes.
again, very thank you, sir. सर मैं देख रहा हूँ सर कुछ क्वेश्चन हो तो एक बार मैं देख ले रहा हूँ सर.
Sure.
So it's my humble request to all doctors, if you have any query related this rabies or rabies vaccine, so you can talk with our senior sir by commenting on this link.
Is there any question in the chat box? If there are queries, we can get in the chat box and we can answer later on also.
Sir, I think no one having any query. So सर कोई क्वेरी नहीं है सर. एक बार फिर से सर आप very thank you for your support sir, for your effort.
Thank you very much for the opportunity given to me for this presentation. Thank you, Kerala team. Thank you very much.
Thank you sir. Thank you very much.
ज़्यादा लंबा खींचा 8 मिनट इससे पहले डिस्टर्ब हुआ.